So this being the lipodystrophy workshop, we still talk about fat, perhaps these days more in the context of fat being a regulator of the hormones that control glucose metabolism and insulin resistance. And what do you think we've learned at this meeting that's new in that area about insulin resistance and glucose metabolism?
I think for me as a clinician, the things that I learned is that some of the new drugs are less associated with insulin resistance than some of the older drugs. Some of the basic science presentations, I had more a difficult time to try to extrapolate into the clinical practice to understand the clinical implications of those observations in vitro. I think they will help us to understand better the mechanisms and why these things are happening, but I think there is still a long way to make it translation into practical care of the patients.
One of the unusual aspects of fat redistribution was the facts that one type of fat depot seems to shrink in people who are HIV infected, while another fat depot tends to increase. And it's always been hard to understand why treating people with the same medicine would cause the fat in the legs to shrink and the fat in the back of the neck to grow, or the fat in the belly to grow. What could it be that makes those two fat depots so different? Two presentations here did not necessarily answer the question, but they highlighted the fact that they really are different. Investigators were actually able to get intra-abdominal fat as well as subcutaneous fat and look at the various genes that would be related either to the growth of fat or inflammation, and showed that it is true that those fat from the two different depots seem to respond differently, and respond differently in a way that would suggest that one depot of fat in one area really could shrink while another one does not. There unfortunately was no good explanation as to why fat would increase, for example, in the belly or behind the neck. But certainly the factors that would lead or that could lead to fat loss in people who are given drugs like stavudine or zidovudine, which you may know as AZT and Zerit, why they might affect the skin, the fat under the skin, but not necessarily affect the fat in the belly.
Well, I guess before we go, I should probably ask you, as both researchers and as treating clinicians, if you have any take-home messages for other providers and for patients in terms of what you've learned and how we can apply it to HIV clinical care.
Well, for now, no new drugs, no new treatments, no new approaches, and at least in our minds, a renewed understanding that what we see when we look at somebody who's HIV infected may be related to HIV, may be related to the person, may be related to other comorbidities, and may just be some form of aging, much like we would see in anyone else. Any of those, if it causes you to have a heart attack, you have a heart attack. If it causes you to have a stroke, you have a stroke. We have to treat it not as though this is just lipodystrophy. We have to treat this as, in people who are well controlled, wellness.
To me also, and it's not only in this meeting, it's the theme probably of the last year and a half is that having ongoing HIV viral replication is not a great idea, that having viral suppression with a drug regimen that is not very toxic and is well tolerated should be the goal for almost everybody infected with HIV, and that we need to learn how to manage all these complications that might be associated with HIV treatment, might be associated with HIV itself. But I think we need to get to be better clinicians, and we are going to be taking care of patients with HIV for the next 30, 40, 50 years, and we better get in line to do the right things that we need to do, control blood pressure, smoking, checking the bone density, making sure that they don't if they have coronary risk factors, that we control the lipids and that we use aspirin. So I think the theme is that we need to come back to be good internists, because the patients are here to stay. The drugs are less toxic, but patients continue to have complications, and we need to take care of those.
I agree. I think one thing that jumped out at me is, and certainly in talking about insulin resistance, is that there's a big role on the part of the patient to play in terms of controlling diet and exercise, and that there is no silver bullet in terms of changing your HIV meds or adding another drug to your regimen, that it's people, both patients and their providers, need to take a more holistic view as to how to address it, because it's a bigger problem than can be addressed by then just one pill.
Thank you very much.
Great, thank you.